Welcome to the clinical genetics ground one again, and I hope this kind of post the NCAA championship day. I hope you enjoyed the Husky game last night, and then congratulations for UConn for sure, Husky. And we were looking for which day in the year we're at that stage. So I'm delighted to introduce Karina Brierley, our senior genetic counselor from the Smilo Cancer Center. Just chatting with her, she's been here more than 20 years and is one of the probably senior genetic counselor in our system. She finished her training in Brandeis University and then came to Yale and never left Yale for a long time. So her experience definitely would be valuable for us. And a lot of her kind of shows you new development for the cancer genetic testing, particularly. I think I'll be looking forward to listen what's the liquid biopsy testing up to date right now. Karina, thank you again for taking time to present us, and looking forward.
Thank you for having me. So today I'm going to talk about identification of incidental germline mutations by liquid biopsy testing. As I said, I'm Karina Brierley. I'm one of the genetic counselors with the Smilo Cancer Genetics and Prevention Program. And although I know probably not, this is in my love, which is cancer genetics, but maybe not as relevant to everyone, but I think just gives us an idea of kind of the new ways that individuals and families will come to us with testing and mutations identified by different means. So just novel ways that families are going to come to us in the future. And I have no conflicts of interest to disclose. By way of overview, so today I hope to talk a little bit about some brief background and overview of liquid biopsy, review the data that we have regarding incidental germline mutation identification by liquid biopsy testing, and then discuss a few recent relevant cases seen through our practice involving liquid biopsy results. So as by way of background, really the presence of cell-free DNA has been known about in blood plasma and serum for a long time, first noted in 1948. And in 1977, researchers remarked on its presence in the peripheral blood of cancer patients. Advances in technology and techniques, particularly next generation sequencing, were really necessary to make use of this knowledge. And the term liquid biopsy was coined over a decade ago to refer to using a blood test to provide the same information regarding a cancer diagnosis as a tissue biopsy. And liquid biopsy can really broadly refer to different methods for analyzing tumor biomarkers, either from blood or other bodily fluids like urine, saliva, cerebrospinal fluid. And the analytes can really refer to any number of things as well, including circulating tumor cells, circulating tumor DNA or ctDNA, proteins, and or extracellular vesicles. However, currently it's most commonly used to refer to the analysis of cell-free circulating tumor DNA from plasma samples. So we all know tissue biopsy is generally considered the gold standard when we're talking about a cancer diagnosis. And tumor tissue from either biopsy or surgical resection is the standard source for DNA for genomic profiling. Genomic profiling has become really a mainstay of cancer treatment, particularly for those advanced cancers. And the focus of genomic profiling primarily is to identify variants in specific genes to predict sensitivity to targeted therapies. However, we do know that tissue diagnosis and/or genomic profiling can be limited in some cases because sometimes there's little or no tumor tissue that's accessible or available. So more recently, some assays have been developed for genomic profiling using circulating tumor DNA, which can overcome this limitation. And so now there's several commercially available liquid biopsy tests. Several of those are approved by the FDA as companion diagnostic tests. And the NCCN, which is the National Comprehensive Cancer Network guidelines, which are kind of a mainstay of guidelines in oncology and cancer genetics, support the use of liquid biopsy in several situations. And so it's really becoming more a part of routine clinical use. So when we think about cell-free DNA, it's this naked, free-floating DNA that's shed or released from cells. It occurs under normal circumstances from healthy tissue due to cell turnover or active shedding. There's no known clear function, and it may just be simply a cellular waste product. It does have a very short half-life, about 1 to 2 hours, and it's short fragments between 160 and 180 base pairs. And it has been noted that there overall is a higher level of cell-free DNA in patients with cancer versus those without. The circulating tumor DNA, or ctDNA, is referring to the proportion of that cell-free DNA that is tumor-derived, and it usually accounts for only a small percentage of the total. So when we're thinking about ctDNA variant allele fractions, they usually range from less than 0.1 to 10%. Higher variant allele fractions are associated with an increased tumor burden and poorer prognosis. And the level of the circulating tumor DNA in the blood can vary with treatment, both with regional treatments and systemic treatments. So surgery, chemotherapy, targeted and immune therapies can all decrease that circulating tumor DNA. And people are looking at multiple potential uses across the continuum of cancer care, but most of them are still in their infancy. When we're thinking about using circulating tumor DNA, it does require some special care because of that short half-life and that small allele fraction. So it's isolated by separating the plasma from whole blood using a double centrifugation process. It should be isolated within hours to prevent lysis of the white blood cells and contamination with genomic DNA. It requires dedicated equipment to avoid contamination, and EDTA tubes, those really need to be processed within hours, but there are some special tubes used specifically for cell-free DNA that have cell membrane stabilizing preservatives. And oftentimes molecular barcoding and other techniques are used to improve detection and discrimination of those true mutations from artifact. So this is just a schematic kind of showing a liquid biopsy process, and then also at the bottom, some of the clinical applications that are being thought of in cancer management. So everywhere from early detection and screening through localized cancer, metastatic cancer, and refractory cancer, although probably the biggest sector right now is in the metastatic cancer setting for treatment selection and monitoring of response. And again, just another kind of schematic showing, we have cell-free DNA, circulating tumor cells, circulating tumor DNA, which may be coming from those circulating tumor cells or directly from the cancer itself. And just a comparison. So when we think of circulating tumor DNA versus tissue sample, obviously a tissue biopsy is more invasive and challenging to obtain. And serial testing is just more challenging with repeat biopsy or tissue analysis. So circulating tumor DNA is an easy way to kind of get around that and be able to serially test. And so that's kind of the future beauty of that as a way to monitor progress. At the same time, there's not a correlation specifically between circulating tumor DNA and the histology or cellular phenotype, so that's kind of a downside. It also gets around the fact, though, that you're able to look at representation of the whole tumor rather than just one small area that you're biopsying, although there may be still some bias in terms of which tumor DNA gets through. And, again, some other kind of benefits and downsides for each. So this is just to point out, that there are locations within the NCCN guidelines that do refer to liquid biopsy. So it is really becoming part of standard processes and treatments. So for non-small cell lung cancer here, and also breast cancer, referring to either tumor or liquid biopsy as a source for identifying mutations that would make patients eligible for targeted treatments. So when thinking about what is the likelihood of us finding incidental germline mutations in circulating tumor DNA, kind of the starting point for thinking about this came from a lot of data that we have about what's the chances with other standard tumor profiling that we identify incidental germline findings. So over the past 5 to 7 years, we have a fair amount of data regarding that. So in summary, what we know is that unexpected actionable germline mutations are common among individuals undergoing tumor sequencing. It happens about 5 to 10% of the time. Even in tumor testing strategies that don't use a matched normal DNA, we will frequently encounter these findings since the vast majority are retained in the tumor. The vast majority of patients also indicate that they're interested in learning about these incidental clinically important findings that are identified in the process of tumor sequencing, even though that's not the primary focus of the test. It's also important to establish appropriate pre-test education to inform patients that this may be something that happens. And especially in the case of this population of patients which have advanced cancers, identify appropriate post-test result communication protocols so that we can get the information into the right hands if the patient, especially for communicating to relatives if the patient is deceased. So, obviously the main, benefit from this is that we can identify family members that may be at risk, but that's going to fall short if we don't have a process in place to do that. We also know that the results of this testing can reveal that the spectrum of cancers that we typically think of as associated with these syndromes may be broader than we currently recognize. So then switching gears to the data that we do have regarding incidental findings of germline mutations in patients undergoing a tumor liquid biopsy testing. So this was a publication from 2018 in JCO, identification of incidental germline mutations in patients with advanced solid tumors who underwent cell-free circulating tumor DNA sequencing. So this was a non-interventional observational case series with coded data from over 10,000 cell-free DNA samples from over 10,000 consecutive patients that had advanced solid tumors. They underwent Guardant 360 liquid biopsy testing that was a 70 to 73 gene panel between November 2015 and December 2016. And they looked at variants in 16 clinically actionable genes with a defined hereditary cancer association. And so you can see them listed there, some of the typical players, so APC, ATM, BRCA1 and 2, CDKN2A, MLH1, NF1, and so forth. Important to note, full sequencing was performed only for some of these genes. The rest were just selected exons, which is not atypical of tumor profiling. So what they looked at is they looked at all variants that they suspected to be potentially germline based on the variant allele fraction falling between 40 and 60%. And they screened those to determine if they thought that those were germline pathogenic variants. They also looked at those that had a variant allele fraction above 60% with a concomitant copy number variation, and looked at equivocal cases on a case-by-case basis manually. And those were ones where there was more than one circulating tumor variant at that variant allele fraction greater than 30%. They excluded variants seen at greater than 2% allele frequency in population databases. And then they looked at the pathogenicity of the remaining variants using ACMG guidelines and a bioinformatics platform. All of their suspected pathogenic, likely pathogenic, other frame shift, start losses or gains, and splice site variants were manually reviewed by a genetic counselor and also an individual board certified in molecular diagnostics. They had over 50 cancer types represented, but a large proportion that were lung cancers, breast cancers, followed by colon, prostate, pancreas, ovarian. The average age was about 63 and about an even split between male and female. And they had 239 potential germline variants in 227 unique patients. Of these, 34.7% were excluded because of a high ctDNA load, making the determination between germline and somatic origin unclear. About half of those that were excluded were in TP53, followed by APC, RB1, and P10. And the majority of those excluded variants were consistent with what we know about somatic mutation spectrum of the respective tumor types. So the majority of the excluded TP53 variants were in lung, breast, and colon cancer. The majority of the APC variants were in colorectal cancer. About a third of the excluded RB1 variants were in non-small cell lung cancer, which is an indication of potential small cell transformation. And about half were P10 variants in breast cancer. So in the end, they had a total of 156 mutations in 156 patients, which is 1.4% of the total, were considered likely germline, and those in BRCA 1 and 2 were the most common, so 78% of the total. Among 12 individuals with multiple samples that were evaluated, the putative germline mutation identification was consistent with that serial sampling, with variant allele fractions ranging from 42 to 56%, and the largest intrapatient variation about 7.3%. The highest prevalence of putative germline pathogenic variants was in patients with ovarian cancer, followed by prostate, pancreatic, and breast cancer. Not surprising since BRCA 1 and 2 were the most common. And they did see higher rates of likely germline pathogenic variants in younger patients, so under 50, across all tumor types, both including and excluding breast cancer, and looking at only breast cancer. So this just kind of shows the breakdown. So as we said, about 1.4% of the total had a putative germline variation, many of them in BRCA 1 and 2, followed by CDKN2A, and then a spattering of others. Not surprisingly, if you look at specifically ovarian and prostate cancer, we said higher rates with mostly BRCA 1 and 2 represented, same for breast cancer. And you can see the rest of the data there. They only had a small number of germline DNA test results to confirm germline mutation status. So for only 5 patients did they actually have a test result. For an additional 6 patients, they had a clinician report confirming that there was a germline mutation, but they did not have the actual test report. They then also looked at an additional 19 of the BRCA pathogenic variants that were found were founder mutations, and they were mostly in breast, ovarian, and prostate cancer. So kind of supporting those being true germline mutations. And then 1 patient had a Brazilian P53 founder mutation, and it was a 38-year-old patient with breast cancer. So again, all of those founder mutations likely are to support or confirm germline status. So by way of conclusions, really they found there is a significant rate, but a lower rate of germline pathogenic variants, 1.4% compared to other prior tumor profiling studies. But they had a conservative approach, which may underestimate the true prevalence. So many labs use a cutoff of greater than 25% variant allele fraction when considering germline, and they used 40%. There were higher rates of putative germline pathogenic variants in people under 50 and those with ovarian cancer. And the vast majority, 93% of the mutations excluded due to high circulating tumor DNA load were in TP53, APC, RB1, and P10. And these are frequently mutated in cancer and often early in the cancer development process. So therefore, they're more likely to have those high variant allele fractions and challenging to discern whether they're germline or somatic in the plasma of patients with advanced cancers. No mutations were excluded due to high circulating tumor DNA load in ATM, BRCA 1 and 2, RET, MLH1, or SMAD4. These are less likely to be early somatic events, and therefore suspected germline pathogenic variants are more likely to be truly germline if they're identified in a cancer where a somatic event in these genes would be uncommon. Limitations, the germline DNA was not available for confirmation in the majority of cases, and they did not have clinical data beyond what was provided on the test requisition form. In terms of implications for what does this mean for clinical practice, it means that the majority of pathogenic variants in genes that we see in circulating tumor DNA analysis are really going to be those somatic events, and only a small fraction are germline. But germline pathogenic variants can be accurately identified in circulating tumor DNA. However, clearly it's not a replacement for germline hereditary cancer gene testing. That circulating tumor DNA analysis may extend the identification of germline pathogenic variants, that patients should be informed prior to testing that this is a possibility, that we may find incidental germline information. And again, kind of establishing those best practices for counseling patients about this potential and ways of getting those germline results to patients and their families. Future studies should aim on assessing ways to enhance confidently calling germline pathogenic variants in a variety of settings with bioinformatics that account for high ctDNA load, germline mutations with lower variant allele fractions, and so forth. So the second paper that I'd like to review is this paper from 2021, which looked at kind of this question from both angles, but looking at identification again of germline cancer predisposition variants during clinical ctDNA testing. So this was done at Indiana University Precision Genomics program. And as I said, really looked at this problem from two angles using two cohorts. So the first cohort was patients with a known germline pathogenic variant who had matching ctDNA assessment, and looking at the ctDNA results for that pathogenic germline variant, and looking at the correlation between how often can we see that germline variant in the ctDNA. And then the other kind of looking at it from the perspective of the previous paper, really looking at patients in cohort 2 that had a variant in the ctDNA with a variant allele fraction, again, in that 40 to 60% range, and looking at comparison germline status. And they considered the genes listed here, again, some of the main players as we talked about ATM, BRCA1 and 2, and so forth. So this is cohort 1. You can see there was a range of ages, about a 50-50 split male and female, mostly Caucasian, a lot of breast cancer, followed by sarcoma, colon cancer, ovarian cancer, prostate cancer. And in this case, they had 156 pathogenic germline variants that were identified. And they had ctDNA results using Foundation 1 liquid biopsy for 86 of those patients, so 91 variants. And of those, about 40% of the pathogenic germline variants were identified by the ctDNA analysis. And the most common, again, were BRCA2 and BRCA1. The variant allele fraction for the germline mutations ranged from 39% to 87.6%, with a mean just over 50%. And the vast majority had variant allele fraction between 40 and 60%. About 60% of the known germline pathogenic variants were not identified on ctDNA analysis. Most commonly this is missed just because the genes of interest were not included in the analysis by the laboratory doing the ctDNA analysis. So it's really just that the gene of interest is not part of the panel that they were looking at. So most commonly this was CHEK2 and ATM, which were not a part of the initial analysis and then were later added. And really, all of them were either that the gene was not included, or there was discrepancies in the interpretation of the pathogenicity between the lab performing the ctDNA analysis versus those doing the germline testing. So in a couple of cases, they were listed in the appendix as a variant of uncertain significance. When they did add ATM and CHEK2 to their analysis, they did identify all of the pathogenic variants in those genes. So this is just a breakdown of, they started with 156 variants. They had matching data for 91, 40% of them were identified, and the vast majority between that 40 to 60% allele fraction. 60% were missed. The vast majority of that was just exclusion of the gene from the assay. And so you can see here, they looked at the missed versus identified. BRCA1 and 2 were always identified. CHEK2 and ATM here, you can see they were missed until they then added them to the assay. So that's what the star indicates. And then the cross indicating all of these here that were missed, it's just because the gene was not included. And the ones missed because of differences in classification were CDK and 2A variants. Their cohort 2 was over 4,000 variants identified in over 1,200 patients. They had 130 patients that had an evaluable candidate germline variant with a allele fraction between 40 and 60%. And almost 70% of those were found to be germline. Again, the most common being BRCA2, BRCA1, also CDH1 and NF1. And kind of again, consistent with the last study, only TP53 and APC were more likely to be somatic in origin when that variant allele fraction was between 40 and 60%, when they looked at genes with at least 5 cases for analysis. So TP53 were germline in only 25% and APC in only about 16.7%. Cohort 2, just demographics, were similar to cohort 1 with a range of ages, about a 50-50 split, female male, mostly Caucasian, a fair number of breast cancer, in this case, some more colon cancer, but also sarcoma, ovarian, lung cancers. And again, they had 380 variants between 40 and 60% allele fraction. 223 of those were in cancer predisposition genes, and they had paired analysis for 160. And when they looked at those, they confirmed germline for 70% about, and somatic for 31%. So again, looking at percentage germline, again, very high percentage for many of them, with the exception of TP53, again at 25% and APC at only about 16%. And this is just a nice graphic representation of that. So if we look at the somatic, confirmed somatic mutations, you can see TP53 and APC are at the front of the line, whereas if we look at germline, it's BRCA2 followed by BRCA1, and TP53 and APC are further down the list. So by way of conclusion, again, in this study showing plasma ctDNA variant allele fraction can provide insight into the origin of the variant germline versus somatic. Known germline variants identified in circulating tumor DNA had a variant allele fraction between 40 to 60% the majority of the time. And about 70% of the circulating tumor DNA variants in hereditary cancer genes with a variant allele fraction in that range were confirmed to be germline. Pathogenic variants on ctDNA analysis with an allele fraction between 40 and 60% then should be considered for confirmatory germline testing. However, ctDNA testing is not an acceptable replacement for germline testing. And also not all patients with variants in that variant allele fraction around the 50% range will be germline, especially if it's TP53 or APC that we're talking about. And so clinical judgment based on personal and family history remains an important part of the process. So going back to kind of our gold standard that we use of the NCCN guidelines, this is for hereditary cancer testing criteria. So you can see one of the criteria is a pathogenic or likely pathogenic variant identified on tumor genomic testing that would have clinical implications if it were identified as germline. And there is a footnote saying this also applies to circulating tumor DNA. So switching gears to a couple of cases, this is the patient that I saw through our St. Francis program. That's why it's a hand-drawn pedigree, because we don't have our computer pedigree system up there. But this is an 81-year-old who was diagnosed with colon cancer at age 79 in 2021. It was an invasive, moderately differentiated adenocarcinoma. Mismatch repair IHC for Lynch syndrome screening was intact. It was a large tumor and node positive. She had had surgery and FOLFOX chemotherapy. Unfortunately, she had progression and metastasis on FOLFOX, and she had had a liquid biopsy to explore other treatment options. And she was referred to us due to, the question of some CHEK2 variants identified on liquid biopsy that just kind of raised the concern with her providers. When we look at her tumor testing, the percentages you can see of the allele fraction is quite small for all of them. It's under 1%, which is what we'd expect for those just tumor circulating tumor DNA variants, somatic variants. And at least one of these is a variant of uncertain significance, but this is what raised the red flag for the providers there. There's two CHEK2 variants. When we look at these, really, this one here is a variant of uncertain significance in ClinVar. This one is a frame shift change. Again, the fraction is quite small. So when I met with this patient and her daughter, I talked to her about, the variants that we see are at low percentages, and one is a variant of uncertain significance. She does have a personal history of colon cancer and some cancers that could be in the Lynch syndrome spectrum with esophageal and kidney cancer, but she had normal screening results on her tumor, which reduced that likelihood. However, really the question had been raised about the possibility of a germline mutation, and she and her daughter were really concerned. And so we talked about testing options to kind of err on the side of caution, give them some peace of mind, and they chose to proceed with panel testing. Not surprisingly, she had completely normal negative test results on a large multi-gene panel. So that kind of put that to rest. This is a second patient also seen through the St. Francis system, who's a 64-year-old diagnosed with lung cancer at 63. It was non-small cell stage 4, treating with chemotherapy and radiation. And she was a current smoker with a long smoking history. She was adopted, so she had some limited information about family history that she had kind of heard through various relatives that she was in contact with, but didn't have a whole lot of details. So there was word of several breast cancers maternally in aunts, and possibly a paternal relative that was either an aunt or a half sister. And she was referred due to this vague family history of breast cancer, as well as BRCA findings on her liquid biopsy. So you can see here, certainly the variant allele fractions were much higher than in the last case, between 30 and almost 60%. This is an RB1 variant, and then these were the ones that kind of raised question from her team. Oh. So again, I talked to her about, I really don't think that this RB1 is a germline mutation, given the lack of a history consistent with retinoblastoma. We talked about that one of the BRCA1 variant is a variant of uncertain significance. But again, kind of whenever these questions are raised, sometimes it's hard to put that to rest without further testing for patients. And in this case, she had just very limited family history information with some breast cancer history. So again, we erred on the side of caution and did panel-based testing. And in this case, essentially normal test results. So she had 2 variants of uncertain significance, but in different genes, HOXB13 associated with prostate cancer risk, and RAD50, which has probably a moderate breast cancer risk, but none of the variants seen in her tumor or her circulating tumor DNA. And then the next 2 cases were seen by one of my colleagues in our program here in New Haven. So this one is a 77-year-old diagnosed with prostate cancer at 67, and then cholangiocarcinoma at 76. He was treated with chemotherapy and immunotherapy for the cholangiocarcinoma. Again, his family history is not completely clear, but reported that either his mother or his sister had ovarian cancer, the other had cervical, and his sister may have also had breast cancer. And he was referred due to his personal and family history, but also his liquid biopsy results. So these are his liquid biopsy results, and you can see here that his variant allele fraction is higher in that 40 to 60% range for this BRCA1 variant. And if you look at this variant, this is actually one of the BRCA1 Ashkenazi Jewish founder mutations. So this really made us more suspicious that this could be real. And in fact, upon panel testing, this confirmed that the BRCA1 pathogenic variant was a germline variant. And then finally, this is a 74-year-old recently diagnosed with pancreatic adenocarcinoma, being treated with chemotherapy, also had liquid biopsy testing, and he was referred both based on his personal history alone, which would qualify for testing, but also his liquid biopsy results. I kind of zoomed in on the family history because it's a pretty large family and really not much that's contributory. There's several older lung cancers, an older head and neck cancer, and then an older colon cancer, but nothing really too suspicious beyond his own diagnosis. But this is his tumor testing from his cell-free DNA. And so BRCA2 frame shift variant at a 49% fraction. And he had testing through our Yale DNA lab, and they did confirm that this BRCA2 variant was pathogenic and germline. So in summary, liquid biopsy circulating tumor DNA testing can identify incidental germline pathogenic variants, although at least at this point, probably less often than tumor tissue genomic profiling. That the vast majority of pathogenic variants in genes identified in circulating tumor DNA analysis are somatic events, and it's only a small fraction that are germline. That circulating tumor DNA is not a replacement for germline hereditary cancer gene testing. However, liquid biopsy results should raise the suspicion of a germline origin in some situations. So when there's an individual variant with an allele fraction in that 50% range, when the variant would be identified as pathogenic if it were a germline in origin, and particularly if it's a known founder mutation, when the personal and family history are supportive of or suggestive of a hereditary cancer syndrome, and a higher rate among younger individuals under 50. Some variants with those higher variant allele fractions may not be as suspicious for germline origin. One, if there's several variants with that higher variant allele fraction or a higher overall circulating tumor DNA level, those, as we discussed in TP53, APC and colon cancer, RB1 and lung cancer, or PTEN and breast cancer. And then providers should be informing patients prior to ctDNA testing that incidental germline information may be discovered. And we need to establish practices for counseling patients about this potential and ways of really getting those potential germline results into the right hands, especially for patients with advanced cancer where they may be deceased by the time we get information back. These are my references, and I will take some questions if people have questions.
Wonderful, Karina. That was a very comprehensive review. Question, comments to Karina?
I have one. Hi, Carrie.
Go ahead.
So, thank you. Hi, thank you. So I have two questions. So you've shown data from, well, data like pedigrees from 4 people. Have these 4 people got into the clinic in the past year or in the 10 past years? That's number one.
These are just the past, really probably 6 months to a year.
Okay,
So.
I'm trying to get an idea of how frequently are we going to start seeing these patients. That was one. And the other one is, are we, as you know, in Smilo, going to determine if we get all these patients, because 2 of the patients, the allele frequency was very low. So you did testing, but that is like, you know, I'm kind of trying to put this in, are we going to start doing a ton of genetic testing for people that really don't need it now, when we have to do a lot of genetic testing for people that needs it? That was one.
Yeah.
And trying, because, and then are we going to determine, are we going to put some guidelines in our clinics saying, no, we are the last two ones. Yeah, they were making sense, right? So
Yeah.
we should do it. So those two concepts that we're going to get a lot of these results now, and just kind of a discussion.
Education. So I think it's also educating the providers, like which situations really raise the question, like from these studies. And so I think that's one. I think the second is really, we see a lot of low risk patients, and because testing costs have come down a lot and people will access it one way or the other, we pretty much offer patients out of pocket testing, even if they're low risk. So just to give them kind of a responsible source of information. Like if they're worried and they're willing to pay out of pocket and they're going to do testing anyway, in some ways better to have it through a process. But obviously, we already are thinking that we need to identify better methods, obviously, of getting these people good information and testing and education. But, obviously there's also a large volume of patients, and we're going to have to find ways to address this in other means.
Thanks.
Bonnie?
Hi, it was a great talk. I was just, so two things. My first one, I'm from YCGA, Yale Center for Genome Analysis, and I would like to actually, tell you that we have developed recently many different platforms for cfDNA testing, and so we should have a more conversation about how we can actually, you as a hospital can use some of the services that we have at YCGA, and how we can develop some lab developed tests for cfDNA based testing. So that is kind of like my pitch. Second thing, question wise. So we actually recently looked at glioma samples and some of the neuroblastomas, and then our actually data was almost opposite to this. So we were actually seeing more correlation between with cfDNA and the tumor at the germline variant calling compared to somatic. And we are still actually assessing why we are actually seeing that discordance. And we are trying to actually use a different kind of aligner and then some kind of other tweaking with the sensitivity of some of these variant calls. So we are still doing that. So my question is that do you think this has to do with the various cancer type? Like some cancer type actually predominantly will be giving you out somatic variants in cfDNA compared to others. So and the second question is that other non-genic characters like methylation, combination of methylation data with so methylation of cfDNA along with the variants will increase the possibility of a better interpretation of these results. So what are your thoughts on that?
I mean, I think it's still early in terms of our understanding, right? I think we just haven't looked at enough. And so it sounds like, and I default to your expertise from that standpoint, having more looked at it from the clinical perspective rather than the testing perspective. But I think just like with TP53 and APC that they show that there's going to be some variants in some tumors that probably, depending on the balance of, how frequent there's germline pathogenic variants that are involved. We know that some tumors are more likely to be, inherited or have a germline variant than others. And I think there's probably some that are going to be more likely to have some of these early somatic events that then are in a high fraction in the circulating tumor DNA. So I think it's going to be sorting out, that there probably is going to be some variability to, the correlation between the two, depending on the tumor type and the particular variant that we're looking at. But that's just my sense, and I don't know that from a data background yet, anyway.
So you think like when we are doing this kind of analysis, it's always good to focus on a set of genes and set of pathogenic variants rather than looking like a whole, like genome wide and trying to interpret that at the whole genome wide.
Oh, in terms of like whether we're reporting whole genome?
Yeah, not the terms of reporting, even for the analysis side. So just confining our analysis to known variants, known gene, compared to everything and anything kind of.
I mean, I think we're probably moving towards whole genome eventually. It's just kind of where we put that in context. And how we use the data, how we analyze the data. I mean, I think from the standpoint of cancer treatment, they're only looking at not even full sequencing of a lot of these genes. It's hotspots. And it's mostly because the aim is for targeted therapies. So, unless they have a targeted therapy that's proven, that's accessible, there's really not a reason to do that. So I think that's from the perspective of it depends on what you're using it for, I guess.
Mohammed?
I have just a quick comment. Yes, we are very focused on target gene because that related to the therapy when we do the oncomine. Advantage in oncomine, we are 146 gene. We have match normal, so it's so easy to tease out the germline variant. So we don't report any benign VUSs likely. We only report pathogenic variant 100%, and we recommend genetic counseling. Another thing, the circulating tumor cell-free DNA, it depends on the cancer type, and it depends on if there is metastasis or not, or it's oligometastatic, because not all tumors shed DNA in the blood.
Yeah, so I mean, that's a lot of what they're looking at and using that kind of across the spectrum of cancer care is, looking at that there are higher rates when it's metastatic and when people are not undergoing treatment, and using it to monitor for resistance. So, I mean, obviously there's a lot of things kind of beyond what we're looking at it for from the perspective of inherited, that a lot of it is, could we use this for screening down the road? Although probably difficult because it's probably a pretty small percentage, but screening, monitoring for resistance, and not only just by level of circulating tumor DNA, but what's the mechanism of that resistance, what mutations are involved. So I think, there's just, it's, as I said, really still in its infancy for a lot of these things. And I think we're going to be figuring this stuff out over time.
I would turn to Penny before I turn to Penny. That's one question Kurt was asking, which method it was using for Indiana study for Guardian. Is it Guardian 360 or different one? Karina, do you know that technical detail?
What's that?
The Indiana University study, which method that they use?
Oh, so the first one used Garden and the second one used Foundation 1. So two different commercial liquid biopsy tests.
Then go Penny. Penny. You need to unmute it. Penny, you need to unmute yourself. Yeah.
Can you hear me? Yeah.
Yeah.
Yeah, I have also a quick questions. Like when we consider this kind of testing, is more focused on the variants, somatic variants, or the germline variants. Is there any consideration into the copy numbers, or even sometimes the aneuploidies related to different type of cancers? The somatic copy number variants.
So you're asking whether they took into account copy number variants?
Yeah.
So in some cases they did. They used that to exclude. So they looked at if the variant allele fraction was higher, but there was a copy number variant. I don't know that they looked at, so obviously looked at ones where there was duplication, larger. I don't know if they looked at loss of heterozygosity. I don't think they did.
Actually, I think there's a lot of those copy number variants. Like, for example, the 30q deletion is related to the retinoblastoma, and there are a lot of leukemia, and they have various deletion and duplication, gene application, and sometimes even the gene rearrangement. I'm just wondering if they want to do this kind of things. Is that any way they need to build into their testing profile to include?
Yeah, I mean, I don't know if that's just, because of the, certainly they do that with when they're doing tumor genomic profiling on a biopsy. I don't know in terms of circulating tumor DNA, the feasibility or clinical utility of that. So I think it's, again, kind of a little outside of my range in terms of, I don't use the testing for the purposes of determining treatment, which is what the main purpose is. We're looking at it from the perspective of obviously identifying people with an inherited mutation, but that's not the main focus. So I have a feeling it has to do with where that's applied and how that's applied with, in terms of availability of treatment and using that for treatment decisions.
Yeah, my lab has some very limited experience. Like one time we test some of those patient already diagnosed with some like MDS AML with a known chromosome abnormality like 5q deletion, 7q deletion of trisomy A, all these kind of large copy number changes. And then when we get the patient sample from bone marrow and blood, and then we take the supernatant and then do the whole genome sequencing. Actually, they can find the same abnormality as chromosome detected. So cell-free actually can either do a screening as this test show, and also can do like a follow-up treatment follow-up. But they just need to develop those disease-specific abnormality. You need to look into it. So, yeah, thanks. This is a very systematic review for all the recent publications. Yeah.
Thank you.
Karina, I have a very short question. You may or may not get that detail. I was surprised to see in the NF1 germline was pretty high among the two studies. Is that something just for adult? It's a surprise. Like they just missed the diagnosis and happen to have a diagnosis just picking by this testing, or is it something we have to learn? This is like totally asymptomatic and then just somehow find it by 20 or 30 years of age, and then they finally have an NF1 germline mutation.
Yeah, I mean, I think, you know, so this comes up sometimes with our, you know, germline testing. Obviously, probably a lot of you are getting the same findings, is that as we do more testing on more people, we're finding people with, you know, these possibly mosaic versus germline, and a lot of them are TP53, but we also have seen a fair number of NF1, and we're still kind of sorting out and trying to determine if this is, you know, CHIP, that it's changes, hematopoiesis changes over with aging, or it's truly somatic, you know, mosaic, or if it's truly germline. So I think those are still things we're sorting out. And I think it's just one of these, the more people we test for more things, the more we're learning what we do and don't know. And there's some surprises, and that we're still kind of sorting that out. And that may be also part of this, you know, that they're just seeing those at high fractions. But, you know, in a lot of cases, they weren't necessarily confirmed. Obviously, with that first study, it was just what they suspected. Yeah. So, I mean, I think we don't know the answer, but we've seen it in situations where we're looking specifically at, you know, for germline mutations, and we've found some that, you know, we think are probably mosaic, or where we just don't have answers. Yeah. And hard to answer, right? Like we just don't, we can't test every tissue in every location to really make that answer, but they don't have a clinical diagnosis from the standpoint of a traditional, you know, clear picture of NF1. Yeah.
So that would raise the question sometimes what they call germline versus non-germline, very early somatic mutation versus, I think it's probably useful, valuable to have this patient come back to clinic truly evaluate them details here. Oh,
yeah, and that's a lot of our processes, you know, have them evaluate, have them have a, you know, detailed exam, thinking about NF1, test children to see if we can see if it is germline and inherited by their children, or potentially test another tissue. So it definitely sets off a diagnostic odyssey of more testing through our program.
Great. Any other question, last question, comment about the time? If not, I think indeed that's definitely, it's a very interesting, ongoing, kind of hot topic in the field. And then thank you again for bringing up to us for this platform. Thank you, everyone.
Thank you for having me.